All right. Hey, everybody. Happy Monday and welcome to, no, this is not the old Crossfire TV show that used to air. I am dating myself. But this is the Compliance Guy Monday Auditing, Coding, and Compliance Roundtable. So today we have potentially an abbreviated roundtable discussion. We seriously have two main topics that we really want to cover for everybody today. And we didn't want to go beyond that because we think that these are two topics that are of significance to the majority of listeners and followers of the Compliance Guy podcast and this live program. So without further ado, I want to welcome our great all-star cast of characters: Paul Spencer, Stephanie Allard, Christine Hall, Scott Kraft, and Miss Terry Fletcher. How are you guys?
Good. Hot.
Every week I ask this question, and every week there's a pause.
We're on mute, son.
Oh, okay.
All right. Get a moment to unmute to say, we're doing great.
All right. Well, to each and every single one of our listeners, followers out there, I want to say welcome. Thank you for tuning in, logging on, and hanging out with us for just a little while today as we get to explore these compliance issues. So, Stephanie, I want to go to you first, and I want to talk about the medical necessity of billing for a service, such as an evaluation and management service, just because, and I'll let you fill in the blanks.
Because the patient was seen. So one of the big issues that I have lately is when I come across problems related to medical necessity, meaning policy that, dictates certain conditions or requirements prior to coverage. Or, we've talked a lot already about weight loss drugs and new things that are coming into the industry. And one of the things that I find when I work with clients and individual providers in this area, they don't understand the fact that even though the base management is not considered medically necessary, that they can't go ahead and bill the E&M service because they saw the patient. They don't see that link and relationship there. And the next subject we're going to talk about too, Terry and Christine had brought up the fact that, right now a lot of the practices are looking for other money-making opportunities, right? And it just keeps failing because at the end of the day, when you have different, let's say, salespeople or corporations that are making all of these things that say they're going to make people money, it's not happening. And, I even finished an audit last week where there were different injection procedures being done for the patient. There's coverage for the injection procedure, maybe a frequency type issue, but the providers continued to bill E&M services. So they were billing them along with the injection, which we know that's a big pain point already. But then in addition to that, they were billing it in place of an injection, which part of my conversation I'm going to be having with them is, are you getting denials? What's driving this type of billing behavior? But at the end of the day, we really need to make sure that our providers are beginning to understand the core of compliance, because a lot of times practices go through motions. I'm sure you all have had this, but there's a lot of clients I work with and they're like, oh, this physician's starting next week, but don't worry, you don't need to do an audit or training because he's been in the industry for 30 years and he's really good at it.
Yeah, I'm going to continue that conversation.
Yeah, okay? Come on.
So one of the things that came up for me, and for those of you that have never heard Christine Hall, if you have not heard Christine speak, you need to find one of her programs because she's fabulous. And I don't say that lightly. So somebody who's been in the industry, 40 years, and I've team taught with her, plus I've heard her speak. I've done this with Stephanie, and I think we're all really good speakers. You got to listen to Christine. She has this one webinar and educational piece called not the dissection, but the anatomy of the CPT code. And I came up with a problem. And if you ever want to know how, if you're dealing with something, you want to know how to explain it to somebody, I feel like I'm pretty good at that. I don't want to say dumb it down, but I can give like the actual basics so, somebody can really understand what I'm trying to get to. But I like the way Christine words it. So I had a conversation with her about, I have a provider that is trying to use their RNs or medical assistants to bill the post-op visits after surgery. And after I face planted, I was like, okay, no, you can't do that. And I knew, obviously you can't do that because the surgery codes have post-op E&M services beyond the nurse visit included, and they have to be done by the physician. But in speaking with Christine, and Christine, I'll let you take it after I kind of give the gist here. One of the things that I didn't actually account for, which I thought was brilliant in explaining it, is that you have to look at status indicators. And surgeries don't have incident to status indicators. So first of all, didn't matter what it was, it couldn't be the nurse practitioner or PA even billing it. It has to be the provider. They're getting paid, the physician, they're getting paid for that surgery. So it includes their work on the pre and post-op E&M. But then also, so that's one thing on the incident too. But your RNs and MAs don't have in their scope of license anything beyond nurse visits. So again, you've got things there. And Christine, do I need to add anything to that? But I just thought that was an interesting take, because that I could get around that, or get on top of and go, oh, guess what? And so that was helpful.
Well, I like to think that nobody would ever say, Christine told me. I hope that you all remember Christine showed me. And where does it say that? And where's that logic coming from? So when we're looking at some of these surgical procedures, the CPT code itself has those status indicators, whether or not that service can be done incident to. So for example, like a venipuncture, having a phlebotomist draw your blood, which I'm a huge fan of phlebotomists drawing the blood and not doctors drawing the blood. That is a code that has a status indicator of incident to. It can be done by somebody else with that level of training and therefore reported by the physician. The CPT code itself says that you're allowed to do that. Brain surgery, no status indicator that a nurse can do that. There's no incident to on brain surgery. So anything that it goes with that brain surgery code that you're reporting, that 60,000 code, has to be done by the physician, cannot be delegated incident to anybody, because it doesn't have that status indicator that allows any portion of the brain surgery. So take it a little further down the rabbit hole. Each procedure has already been given the value of its time and skill and intensity, right? That RVU component that we think about. And that time for that brain surgery includes those 2 post-op visits, or 3 post-op visits, or discharge from the hospital. It's included in what we consider to be the expected average amount of time that value is being paid for. So if you're delegating any of that service out, you got to make sure, can I delegate it? Is there an incident to component to it? Or do I have to do it myself? And that's how it reflects that payment there, whether you're entitled to the payment for that follow-up visit or follow-up service. It's just facts. It's not an opinion. It's not a payer policy. It's facts. It's part of the CPT code.
And Paul,
Yeah,
you had
you know
something
what?
to
This
say on that
made
too,
me
right?
really, really quick before you jump in, Paul. You just made me think of something, Christine, that's a huge issue. And Terry, I know you've told us about a scenario similar. So Sean and I are working with a client that's in a very unfortunate situation where they had paid, an organization for specialized treatment. And they're being led down that path where there was not compliance to begin with, and they've put thousands and thousands of dollars into this. And when we talk about the specifics here, Christine, what you were saying with those indicators, Paul, I know you're huge into that data as well. we have to understand that this comes first, and then we've got to look and pair it with things like state scope of practice, what they're able to do, because it doesn't even matter. Even if we have something that's incident 2, we have to look at the whole picture. And Terry, I laugh because I remember you had told me a while back about a situation where I believe it was a physician billing for his nurse, and he said, well, you know, she's been in the industry for so long, why can't she see patients too?
It was one of those Holiday Inn Express moments. I'm like, people, stop. And Paul, I know you and I have, and you had mentioned the time factor, right?
Yep. So I'm wondering if I can share my screen for everybody here. Just give me 1 second. And okay.
Well, while you're doing that, Paul, I just wanted to remind people, I had this come up a couple of weeks ago. I was talking to Kimberly Jolivet Williams, and she works in compliance. We were asking the question about consent for certain procedures that may or may not require it on the payer side. But when we went to the state law required consent. So if the state law requires it, it doesn't matter if the payer, if Medicare requires it, Blue Cross requires it. If the state requires it to be a legal visit, then it doesn't matter what the payer says. So I think that's one thing people have to remember as well, is when we start looking at scope of practice, we start looking at state laws, those are going to supersede, or they're going to trump any type of payer policies that the payer may suggest or require.
Okay, so I'm not sure if the listeners or the viewers can see exactly what I'm sharing on my screen, but it looks like it's in the bullpen for what we're going to share. But what I wanted to show everyone today was its file number CMS-1784F, and this is updated every year. It's called the work time file, and it's updated with every final rule that's released. So what we have, and I'll try to describe it while Sean brings it up. Unfortunately, it's not sharing. But when you pull this file up, and you can go directly to the 2024 final rule and look for something that says work time, I'll see what I can do as far as sending it.
Real quick, I'll send a link over.
Okay. Basically, what this spreadsheet does, and I can talk a little bit about the history of why this spreadsheet was created. About 11 or 12 years ago, we had a situation where CMS was considering getting rid of the global surgery concept and having an allowance for the surgery itself, and then separate allowances for the E&M service in the post-operative period. And so, as an adjunct to that, this spreadsheet was created. Now, that idea, thankfully, was abandoned. But what I came to learn about this spreadsheet is that for every CPT code that's in, particularly surgical CPT codes, what it shows, fantastic. If you can scroll down to line number 4278 on that spreadsheet and make it much bigger than it is, I can have a good example of exactly what I'm doing here.
You said line 4278?
Line 4278, yeah, because this is going to be a common procedure, something that you see every day, in the words of Groucho Marx. Line 4278 is for CPT code 47562, which those of you in the coding arena will understand is for a laparoscopic cholecystectomy. Now, what you see in the first 6 columns, you see the CPT code that's delineated, and then you see all of the time in the next 5 columns that's dedicated to the time elements for that procedure on the date of surgery. So for a laparoscopic cholecystectomy, you have 40 minutes of pre-evaluation time, 10 minutes of pre-positioning time, 15 minutes of pre-service scrub, dress and wait time, median intra-service time of 80 minutes, and then immediate post-service time in a PACU coming to wake up of 25 minutes. Now, after that, you see about 13 columns listing E&M services. So for CPT code 47562, what they have listed is 199212, 299213s, and 1/2 of a standard discharge of 99238. What this spreadsheet is telling you is that in a typical post-op period for that procedure, we are expecting to see the equivalent of 199212, 299213s, and 1/2 a discharge. And when you look at that, those are E&M services. That is not something that can be rendered by an RN or an MA. They do not have the training to provide an evaluation and management service, and they cannot do that. It is part of the global surgical allowance. So, and you'll also notice that the total time of the procedure in column T equals the procedure time plus all of the time elements of those E&M services that CMS has determined. So again, all of this is built into the global allowance. This is not something that can be taken and given to an RN or an MA to perform any part of this. We are expecting that someone with surgical expertise is providing the entirety of this service, including the post-op period. And yeah, I could also go on for about an hour and a half about how to use this for the modifier 22. That's not the reason why we're here today, but I'd like to defer to Scott for the next comment.
You're on mute, Scott.
Sorry, I'm trying to come off mute here.
I think your microphone is
Scott,
available.
we heard you.
Yeah.
And now we can.
No, we can't. Try again.
I think it's great though that while we're getting Scott up here, that you showed us that. I didn't want it to be a webinar or anything like that, but I think, Paul, for some people that are visual people, that they do need to understand that concept already, it has been, the mathematicians have already put together that time concept, and that's what that RVU is based on. If we start cutting corners and we start not doing those post-op visits, or providers stop doing those post-op visits, then it's absolutely going to affect the overall RVUs. It's going to decrease those RVUs. Sorry, Scott, go ahead.
No, sorry, I'm having some technical difficulties today. The only thing I wanted to add to this that I also think is important is giving away the global work to another provider. So we have these modifiers for pre-op only and post-op only. And across my auditing career, if I had $1 for every time I saw that modifier on a claim or those modifiers, I don't believe I would have $1 at this point because I just never see them. But I do see the work given away all the time, right? Or the work ends up being done by another provider. So in a surgical situation for a hospital inpatient, I'll see the hospitalist coming in and doing, or at least documenting, work that's clearly part of the global period of the surgery. And they can't just take the credit for that work by virtue of the fact that they were doing it. One thing I also saw very recently was a group that had engaged with another organization to do RPM services, the remote project management work, or remote patient management, excuse me. And within that documentation, I saw work that was part of what I would consider to clearly be a pre and a post-operative service. And that was ending up being billed by this entity as a part of RPM services. And so you can't just take this work and parse it out to other services or parse it out to other providers, absent obviously the use of these post-op modifiers and pre-op modifiers, but we just don't see those very often. And, the surgeon is usually not looking to concede the payment. The surgeon may be looking to concede the work, but that's an entirely different conversation.
The only time I've seen it is I have actually a client where the surgeon comes down from Northern California and does the surgery and then flies back. And then the Southern
That
California team takes care. And that's the only time I've seen it. And actually that made sense to me because that
Yeah.
surgeon is strictly about the surgery. He's like, I'm not taking care of anything else. So
Yeah.
just something to realize. And well, that makes it the exception. You know, like you said, Scott, you wouldn't even have $1. I think I've got $5 now. So yeah, it's not it's not a big deal. But I wanted to touch on something before we move on to the next topic that Paul said in the time situation. You know, Paul, I think it also goes to going from that chart and from what CMS is doing. If you look at the time qualifications for E&M, it does say time spent has to be personally spent by the physician. And so I think the RVUs for E&M are also, you know, defined within the CPT book as well, not just in the CMS table, but they're saying, look, if you're going to go by time, it's not what you sub out to anybody else. It's not the staff time. It's not that. There are other codes if you need to add that. But for the specific time for your base E&M code, if that's what how you're leveling your service, it's all the time specifically spent by that physician that has to be documented.
Well, over the last decade, we've had a few studies on the value of postoperative services, one by the Urban Institute, and there was another one that was at RAND, thank you, Christina, where they took a look at the value of postoperative services. And the one piece of information that's not available to us, not being in the AMA, and not being members of CMS, is that under every single CPT code, the AMA has files that describes in excruciating detail what activities are included with every single surgical CPT code, from bringing the patient in, putting them in supine position, doing pre-scrubbing, everything that goes into that procedure and the description for it. It would be nice to have that on our end just to see if the work is matching exactly what the description of the CPT code is. But based on the Harvard RUC time study that happens every 5 years on a rotating basis, those things are constantly modified. As things get easier, or as the technology catches up to a specific CPT code, you would see that the median intra-service time is going to go down with it. So it's something to keep an eye on. It's something to compare from year to year. As I said, we've only really had this information at our fingertips for the last 12 years. I think the first time it came out was 2012 when it was publicly available. And again, it was with the idea that we're getting rid of global periods, and really they found that the easiest way to calculate a global period was to keep it a global period. So we still have that spreadsheet as a useful piece of information.
You know, Paul, I was on the global period thing, just a side note, which I find amusing, but not in a funny sense, just that be careful what you ask for, where when they got rid of the globals on hernia repairs, now all the questions I get, I don't know if you guys get them. So what do I bill for a post-op? I'm like, what do you mean? And I said, you get to bill an E&M service. Just like, but what level? I said, well, what level did you do? Well, all we're doing is a wound check. So is there a level for that? And it just, it amuses me only because it was a higher RVU on the hernias, because like you said, it had built in, you know, the E&M, and then they took the global off, lowered the RVU on that. And now people are like, but what do we bill now for the follow-up? So it's almost like they asked for it and said, okay, well, thank you, but now what? So if they end globals for other things, I have a feeling those questions are going to continue, because a lot of post-ops are just checked.
Because the work that we all do explaining E&M levels of service somehow goes out the window when we ask them to bill an E&M level of service. Isn't that something?
So it's kind of funny for that.
Yeah, and one thing I would add, I think that's important, and I was, as I was thinking about how to say this, I feel like I'm sounding like Captain Obvious, but we had started off earlier, and we weren't necessarily talking about the global period, but we were talking about, well, when do you bill and when do you not bill? Most practices that I work with are not out there doing like 100,000 different things. They're doing, most physicians have a reasonably sized subset of services that they perform. And so I think it's important as an organization to understand and set standards as part of compliance really understand the essence of these regulations and rules, like what's behind them, what the impetus is, and to understand like when it's appropriate to bill and to not bill. Because a lot of times when the question comes to me, it's well, how do I get an E&M service into this? Like, how do I, shoehorn? You almost feel like you're trying to make sure you've got the documentation right to get this thing in. And as a compliance auditor who reads notes, I'm certainly susceptible to being fooled by what's documented, right? Like, I'm not in the room, so I'm just looking at what's on the page. And so I do think it's important to understand from a, philosophical regulatory perspective, when is an E&M service appropriate with, say, a therapeutic injection, right? Like, what are the foundational aspects of that from a compliance perspective, rather than thinking about, well, what should I have documented to be able to bill an E&M service? Because it's not about that necessarily, though I understand there's multiple sort of definitions to that question, but it's really just about like, what are the circumstances of the case? What do the regulatory carve outs with regards to things like E&M services? What do they allow? And how do you structure your policies from that perspective, rather than sort of creating this license to just try to create a runway of documentation to get paid for something?
So I agree with you. I agree with everything that you were just saying. I want to ask this question to the entire panel. What Scott was just talking through, does that not rise to the level of subjectivity, right? And I ask that because to make a determination and then to figure out what level of service to actually bill, does this not take us into a discussion that is highly subjective? First off, whether or not an evaluation and management service is truly billable or required to bill. And I bring this up because is it not true that a lot of us take the position that an evaluation and management service is not appropriate to bill ... because the insurance companies have told us that it's not appropriate to bill from a reimbursement standpoint? But what about from a continuity of care standpoint? What about from a quality of care standpoint? So where the conversation started, and I'm just asking this question, right? Where the conversation started with Stephanie, which was we don't bill for an evaluation and management service simply because the patient was seen. Could we not have a counter argument? And I'm just asking this question. Could we not have a counter argument to say we should have an evaluation and management service billed simply because the patient was seen? Because even though the reason that they may be coming back in for is a follow-up of this or not a follow-up, but to have this procedure performed, is it not possible in the week, 2 weeks, a month since the patient was last seen that other things could have come up in their medical history that could require us to ask additional questions? Did they start a new medication that could have a potential contraindication to something that we would prescribe to them post? I'm just asking the question.
You just hit it on the head. You hit it on the head, Sean, though. You just said it. You just said it. Because they've got a new medication, because they've got additional questions, because there's additional evaluation to determine if this is the correct
we shouldn't have to be asking the question. That should be documented so we can.
I'm not disputing. I'm not disputing your point.
Yeah.
The conversation started as an evaluation and management service is being billed simply because the patient was, and I said, Stephanie, and she said, seen. That's where the conversation started. So I'm just trying. It's been very hard for me up until about the 26th minute to just sit idly by, very quiet, muted, without unmuting myself, because I listen, and I want everyone who's watching this program to understand how much I respect the people that are on this panel, because I have lots of opportunities, and I have many folks that have asked, hey, how can I be part of the panel? And everyone who listens and views us live is part of the panel. But these are, as we always talk about, building your trusted circle of resources. So I'm going to pause there because I have a feeling I'm going to get lectured by a couple of my panelists. So
No, I don't. I'm
let
not
me
going to
pause.
lecture. I'm not going to lecture you.
I will in a minute. No.
Well, so when you
Oh,
so-
wow. I've
circle
got
back.
everybody coming at me now. Okay.
no, so when you
It's whack-a-mole.
when you brought up subjectivity, like that got my attention. And one of the reasons that it did is because one of the things that I often say when I do provider educations or I do trainings, much of the provision, if not all of the provision of healthcare services is somewhat subjective. You have a physician or practitioner who's making a decision based on his or her clinical judgment of the patient. And in reality, when I think about guidelines, whether it's E&M guidelines or surgical guidelines or global period guidelines, any set of guidelines that we have put into place is an attempt to take a subjective process and filter it through an objective lens so that you have this set of consistency behind everything that comes through. I've said it before, right? Like when you think about McDonald's, the idea is that like a Big Mac is the same where I live in Washington as it is in Georgia where like Sean lives. And so part of E&M guidelines is like a 99214 over here is a 99214 over there based on guidelines. So to me, when we talk about whether we bill or not, we're looking at like a 35,000 foot view of the guidelines and saying, what is the provider's intent and how do we run that through a consistent process? So I'll give you an example, and this is not to pick on orthopedics, but this is where I commonly see this. So when we talk about minor procedures and the global period, the CCI states that an E&M that prefaces a minor procedure is typically not separately billable. But the way we sort of address that is usually it's not straightforward, at least from a documentation perspective. It's I discussed a multiple of treatment options with the patient on this initial visit, and we decided to proceed in this direction. We decided to proceed with, an injection. So 3 months later, when the patient comes back and we have all this established medical history and nothing has changed about the patient's condition per the subjective, except that the patient's injection efficacy has worn off. When we get to the assessment and plan, when we're running through the exact same list of documentation cues, right? So it's once again, I discussed multiple treatment options with the patient, but in reality, nothing has changed. Nothing about the patient's desired treatment path has changed. Nothing about the patient's condition has really changed other than the efficacy of this one injection. What are we doing there, right? So when I talk about that conversation with the providers about that consistent approach to documentation, it's just understanding, okay, to your point, if you're going to give me a change in the patient's history, if you're going to tell me something else is different, well, then I'm amenable to that conversation. And that includes, by the way, the provider's clinical view that now surgery should be discussed because these injections just can't go on forever. So there's all these different things. And so to me, when I think about it, I'm worried about that sort of standard approach of we're always taking the same level from documentation. And I get back to where I started, right? Like you end up going, the risk is you go down this path and you say, well, how do I get this paid according to these rules? When in reality, it's just taking that step back and saying, what are those circumstances?
Go
Yeah,
ahead.
and
Stephanie.
for me, one of the things that I actually like about the guidelines we're under now, I guess I do view it a little differently because yes, there's still subjectivity there, but I think some of it has been removed from what we had before. Because if we think back to auditing and educating and working with providers on 95 and 97, we could be sitting there and they would say, oh, well, we have comprehensive history and exam. And we would be trying to say, there's this mythical thing out there that we call medical necessity, and that's going to dictate where we fall. So knowing that I don't have to have that type of argument, that was a lot harder to get them to understand that back in the day. And now for me, what I like to do is break it down just simply to the word management, because the end goal of everything needs to be linked to management, like with what Christine was saying. Patients, a lot of times, for example, I have one particular client and I was seeing a lot of frequency and I was questioning it. The patient is new, then 2 weeks later they're seen, 3 weeks later they're seen, and then eventually they go to a monthly schedule. And I said to him, what is driving the frequency? Well, we started him on a new medication and there could be a problem. And, that's one thing. And yes, Sean, I do think that there's an argument in the industry, and there really always has been about, quality of care or, all of that and how it fits into the bucket from the payer side. But these services are not paid for what could happen. So if we don't have that final link of management, we don't technically have our medical necessity for the base of that E&M. So I don't even look at it just as an evaluation, because you could evaluate a patient with no complaint who's perfectly healthy and still not have any game plan at the end with management. So for me, that's been my main goal now under the new guidelines.
Excellent. Paul Spencer.
So, really, and as we always say with a lot of these topics, it comes down to documentation. I'm a guy who grew up in a half Jewish, half Italian neighborhood in Philly. Somebody documents on a medical record, patient presents for injection, and then suddenly we're seeing a lot of different, even though we are no longer counting history and examination as bullet points, you're still seeing medically appropriate history, medically appropriate examination being part of that E&M service. If you're giving me a templated document, where the exam elements could be for the pre-op for the procedure you're performing, in the words of my people, what are you doing? It all comes down to documentation. You've got to be able to have very clear if you're billing two services, I've got to be able to pull two services out of that.
Excellent. All right, Terry Fletcher.
Oh gosh. Okay. That scared me. So as a payer auditor, because I know Sean mentioned, and that you made a really good point, that sometimes we go by policy, not necessarily what's going on in the clinical sense. This is a good point, because here's what I see a lot of, not just as an auditor on the physician side, but as a payer auditor, we do look at policy and for the different payers, for the Medicare payers and commercial plans. But the problem that we come across a lot of times is, and I think our listeners will see this, is that the providers are asking this question: how do I get to a level 4 or 5? How do I get to, what do I need to document to get to capture the E&M on the same day as an injection, on the same day as a patient's presenting? And that time is only blocked for that patient to have a removal of the lesion, or they're coming in for those 3 knee injections and they're on their second injection. That's the only reason they're there. So how can I also get an E&M? That should never be a question that's answered, because that's not, well, I shouldn't say never, but it shouldn't be something that's answered in a way to show them how to manipulate the documentation to capture the service. Because since we've moved into EMR, however many years ago that was, there's always that template in there. But is that really being done? I suspect probably not. And so not a lot of it anyway, unless there's a new complaint, a new problem, an exacerbation, something's changed. And also, Stephanie brought up a good point about, well, there might be a problem. If I see a document where somebody comes in for an E&M encounter and they're monitoring this change in medication, that's fine if they're concerned about that. If I saw it from a previous note that they told them to come in because they were concerned because of the patient's clinical profile. But to not even document that, how do you know that's why they're coming in if there's no complaint? And so to everyone's point about documentation is the key. The reason the payer policies exist is because they also know how physicians schedule procedures in the office. They know they block, and E&M, they block certain time. So for a lesion removal, 20 minutes, for an injection, 15. And there's no extra time typically in a lot of these practices for another E&M, unless there's a problem that's documented that now they have to above and beyond, or as the 25 modifier says, significantly separate service to be able to do that E&M. And I think this is where we have the misconception, misperception here is that just because the patient comes in and you say hi to them, we're going to do your injection, or hi, are you ready for your, lesion removal or whatever we're doing that day as a minor procedure, that you also get the E&M. And it's a problem because this is why so many payers have put out that, well, if you put a 25 modifier on in the same day as a procedure, we're not going to pay you. Now they've rescinded a lot of that because that was too blanketed. But, and I'll send it to you, Christine, I think that on planned procedures, unless the patient is complaining of something else you need to address, remember the first element of E&M, either complaining of something, or let's say even during the procedure, the doctor notices something during that procedure that they need to address from an evaluation, Stephanie, and management situation, then it could be, medically necessary. But to just say it's there because that you see the patient in front of you, we can't manufacture, we can't manipulate, we can't put in documentation just because we have the template to capture that service. So I'll stop ranting. Go ahead, Christine.
Terry, I think that template, honestly, is what is causing a lot of these problems. Is, we've sat and we've talked about the what ifs. Well, what if the patient is taking a new medication? Or what if we do need to evaluate signs and symptoms that they're receiving from that previous procedure that was done? We're missing all of that great information because docs are looking for a button to push. They're just clicking or they're copying and pasting, even worse, because it's the same information from the last visit, but it's really not. And a lot of the times I feel when I'm reviewing this documentation, the medical assistant or the RN who did the initial intake could have put that information in there. Patients here again for a follow-up visit. They were started on a new medication. They're feeling really good about it. There's no additional signs or symptoms, or vice versa. Patient says they get a little nauseous on this medication. They get tired in the afternoon, or they're experiencing something new. Now, that would prompt the providers to ask more questions. But if the history is poor and the exam is unremarkable and you're only pulling over what you did at the last visit, stop asking me about an E&M visit and really start documenting what's in that E&M visit. One more thing I wanted to revisit. I made a little note because I'm a lady of a particular age. I forget things. I wanted to go back to Maya's question. Maya had a comment on there about how they revalue certain specialties or certain procedures. And it almost piggybacks off what Scott said about compliance and having to incorporate review of some of these timesheets in your compliance. So if we're reevaluating RVUs to accommodate budget neutrality every year, Maya, that's where you're going to see that shift in reimbursement for ortho or rheumatology. They're shifting it to allow more in one area or another. But that brings it back to what Scott said. If we don't realize where that shift has happened, or we don't realize where those RVUs have been adjusted because maybe we're not analyzing it on an annual basis, we don't realize that we're actually losing money or gaining money on a particular procedure because we're not looking at the anatomy of that CPT code at least annually to see what's changed and how that affects us.
That's why people don't understand that the E&M codes, which is a lot of practices bread and butter, those RVUs are adjusted all the time when they keep adding these other services for that balanced budget and that balance of that. And I keep seeing these things like caregiver and all these things. I'm just like, what are you guys doing? You're taking from the E&M, which I think that's why that complexity code was put in, that now a lot of the commercial plans said, yeah, too much. But I just think that people, again, Christine, you're right. And put out there when your next anatomy of the CPT code is, because it's so interesting, because people don't realize that they're taking our low-hanging fruit. E&M codes is where a lot of doctors, a lot of practices make their money, whether it be surgical or primary care. And we're getting a lot of that reimbursement pulled from that because of all these extra services being put in there.
Yeah. And I will state very quickly that every year the AMA does mention revalued services as part of the AMA CPT symposium. That should not be considered comprehensive by any stretch of the imagination. These are things that they themselves have asked to have revalued because, again, as I mentioned earlier, the technology has caught up a little bit to the procedure. They're now a little bit more simpler. They can be revalued to a lower RVU value, or as we've seen many times over the last 10 years, they've combined two codes into one that includes guidance or something of that nature, and it now has to be revalued on its own, which includes the guidance. And it's not always equal to 1 + 1 = 2. It's usually 1 + 1 = 0.83.
Well, I think Ginger's comment is very important, and I think she's referencing providers. I find they're typically trained more on the use of the EMR functions and on the importance of free text, status of conditions, and et cetera. And I think personally that the guidelines revisions in 2021 and 2023 were, I think, a win for providers. I think they were important in that we really got away from this notion of what I'll call make work, right? Where I'm talking to a psychiatrist and I'm saying, well, you didn't do an ENT exam, so I have to lower your service. We're just getting into this ability to like explain very plain English what the patient's condition is, how you're treating the patient, examine what you think is appropriate, record the history of what you think is appropriate. And, I think that's been a very difficult adjustment for providers just in terms of that, reticence to decrease the reliance on these templates, the reluctance to move away from some of the macros that they've used historically. But I think also providers have to be cognizant about, and practices be cognizant about creating that unique, plain spoken documentation that tells us what is going on with this specific patient. We have a joke. I know a couple of us have talked about it at DM. That's it's a joke that this community might appreciate, where we talk about how the guidelines enable you to get credit for things that you discuss, but you ultimately decide not to do as a result of shared decision making. And the joke is basically that the patient comes in with a URI and the documentation says, I decided not to do an emergency appendectomy because the patient reports no abdominal pain. So it's kind of like, don't play loose with the guidelines in that way, but understand, right? Like to me, like when I see well-written notes, I will tell the provider, this is exactly, I think, what the essence of these guidelines are. Tell me in the history what's going on with the patient, those medication changes, those things that we've talked about earlier, and diminish the reliance on these sort of canned phrases that attempt to accomplish these various aspects of medical decision-making.
But Scott, Deb, you had, when the first 2021 rules came out, I had providers saying to me, well, Terry, I don't have to do an exam or a history anymore. It says the exam and history isn't there. And I'm like, no.
No.
You have to have a, medically necessary, medically appropriate history or exam. I said, we don't use it to level the code, but we do still use it for medical necessity.
And I think the old guidelines created, and Christine has mentioned this in our comments, but I think at least that's what I think she's referencing. I think the old guidelines were in place for so long, they created this fear that like any little piece of documentation that was omitted was going to have a significant negative impact on the code, because for many years that was exactly the case. Like, how many times did we all have those comments about the missing family history resulting in a 2-level decrease in the code? And so I get it, right? It takes time adjustment, and I will tell providers sometimes I think these guidelines align more with the essence of like a historical SOAP note. Like, tell me what's going on, subjective, objective assessment plan, carve out all of this extemporaneous material, but just explain it in a way that aligns with what you're doing for the patient.
Yeah, I shared this with Scott and Stephanie the other day. It was too good not to share in this forum because it made me laugh. It was so hysterical. You talked about gaming the guidelines. I had a doctor who put in multiple notes, prescription drug management included the decision not to currently use prescription drugs for pain management. Well, congratulations. Everything is prescription drug management now, even when you decide that you're not going to prescribe a medication.
Well, actually, Paul,
nice try.
You know what's good about this? So it says, and I've seen AMA or heard AMA on one of their webinars saying that over-the-counter medication can't be used as prescription drug management, moderate, service.
Oh, well,
and I disputed it. I had a couple pediatric practices where they were giving, they were prescribing adult medication for a child and showed the risk and the management and how they were underdosing just to make sure, not based on what the bottle said. And I said, no, that is prescribing on a physician level. And I didn't agree. So we
the
won.
label said, the label
Yeah,
on all those
the label.
medications say
Right.
under 12 years old, consult a physician.
Right. So they were trying to downcode this pediatric practice, everything from
No.
that was a level 4 to a level 2 or 3. And they were asked to repay, I think it was close to $486,000. And I got it down to 12 bucks. 12 bucks. I was so happy, and it was just the postage. So I was just really mad. I was so angry with this, and I was on the payer side. So the payer didn't like me that day. I was like, no, you guys are wrong. You're absolutely wrong. And I read all the, they're like, no, but look. I go, no, but look. This is this practice. You're reading these rules wrong. And so, yeah. So even though when I say I audit for payers, I don't audit for payers to be on the payer side. I audit for payers and for physicians, and whatever side the audit falls on is what side it falls on. So, it's not one side or the other. But reminder that the rules are there, but they're also very interpretive, and the payers get it wrong sometimes. Medicare gets it wrong. CPT-AMA gets it wrong, or there is an interpretation that actually that can be argued. How about that? I know Christine and Stephanie, you and I, us three have these group texts sometimes, and we know we can argue the rules.
Well, Terry, you hit it on the head. I think that that just woke me up. A lot of practices say I can't afford a consultant. Yeah, well, you can't afford not to have a consultant either. So.
All right. Well, Christine Hall got the last word on this episode. So with that said, I feel much better about what was coming down the pike from play the whack-a-mole game against Sean. I kind of got off pretty light today. So with that said, I want to thank Paul, Stephanie, Christine, Scott, and Terry for joining me on this Monday roundtable for auditing, coding, and compliance. And to each and every single one of you who has tuned in, logged on, and hung out with us for just a little while, you can see why this is such an amazing panel and why we have such great discussions. And we appreciate you spending your Mondays with us twice a month. All right. Terry and I are going to be back tomorrow with a brand new #Terry Tuesday episode. I am very much looking forward to what Terry throws at me tomorrow. I can't wait to hear what the topic is going to be. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.